I want to acknowledge that we're hosting this session, at least I am, on the unceded and ancestral territory of the Coast Salish peoples that include the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, and the Métis Charter Community of the Lower Mainland region. And you are all in your various regions. And as always, I ask us to reflect and learn a little bit more about the place that you're in and the people that came, that have tended the land with us. I appreciate what I think is going to be a wonderful sunny weekend. I also want to acknowledge that yesterday was not only World Kidney Day and declared a national day of remembrance for all the people that died of COVID and have been affected by COVID, but also was National Canadian Female Physicians Day. So there were many, many things to celebrate yesterday, and I want to thank the BC Renal team for their amazing showing and conversations and efforts that they go to make sure that the whole province knows about BC, about World Kidney Day. So thank you all for that. Next slide. So today we're going to talk about our favorite topic, virtual kidney care. And I want to remind everybody who may or may not know Dr. Bevilacqua that he's a clinical assistant professor at the University of British Columbia and a nephrologist with additional training in health administration. He divides his time between clinical medicine and nephrology administration, and he's the chair of the Kidney Care Committee and the medical lead for the BC Polycystic Kidney Disease Network, and is looking at key things in knowledge translation, systems improvement, and evaluating care delivery. And in part of that has been quite interested in thinking and understanding and learning a little bit more. So virtual kidney care was something we never talked about, but he's going to walk us through from 2020 to 2021 and beyond. Over to you, Mike.
Thanks, Adira. Yeah, now it's all we talk about. I went from something we never talk about to the only topic. Let me just get this going here. Okay, and Brenda, that's the right slide you can see?
Yeah.
Those thumbs up, great. Okay, so we'll just launch right into it here. As I get started to this topic, I don't really have anything to disclose. I don't own any stocks in Zoom or anything like that. But the main thing I want to acknowledge is that there's a lot of people working on this. This is not just a me or a kidney care thing. We have actually involvement from across BC Renal in this work. And we have a great collaboration going with the PHSA Office of Virtual Health. Some of these slides actually were specifically made by them. And I do like to acknowledge whenever I've stolen slides for a talk. I had this on. It was just one day late, but it's still good to have this little banner up here about Kidney Day. Today we're going to go through a few things. I'm going to share some of our learnings with virtual health so far and what we plan to learn and evaluate in the future. That's going to be a big bulk of it. But before we start with that, I actually want to just take us back a little bit of a reminder of our philosophy of kidney care. Some of you have heard versions of this before, but I think it's important to reiterate every time we're thinking about moving into a new direction of care. So where we've come from, and this is something that was developed over many, many years, was to have a model of team-based renal care. And this is something we all know and live and breathe, but sometimes once we've been using it so long, it becomes automatic and we don't really reflect on what are the important parts of this. And to me, one of the biggest cornerstones is that our care is truly a team. It is a multidisciplinary team. We have, I see some names listed there, all kinds of different people who contribute within our individual renal clinics, within our renal programs. We have various allied health professionals, we have trainees, we have all kinds of people coming through. And the team also goes beyond that. There's a lot of external people that we collaborate with. Being relevant to kidney care, a lot of our care is shared with primary care providers, meaning, we might just see the patients once or twice a year if it's some of the earlier stages. So the bulk is happening in primary care. And as that spectrum moves forward, then maybe more of it is shifting to us, but of course, still that collaboration. So we have a whole team of people who are involved in the care of our kidney patients because they're complex. And the point that I always want to emphasize is having a team of people really means you have an integrated web of providers. It's a very different thing to have multiple providers kind of working in parallel. So I could have myself as a nephrologist seeing a patient, I could have a dietitian over there seeing them and a nurse over there seeing them, and we'd kind of have this parallel streams of things. That's not really the same thing as having one integrated team who's collaborating and working together to care for the patient. And that integrated team really is what we've tried to foster in our clinics for years now. And so it's important to remember that as we talk about, different models and delivery of care. And our renal care is actually more complicated than some other areas of medicine. And what I mean by that is a lot of the prototypes that we talk about for virtual care really were designed around the single episodic type of thing, right? Somebody has a pneumonia and needs to see a family doctor to get an antibiotic or something like that. Whereas we have these peaks and valleys. That's why I use the picture here throughout our renal care. And we can kind of break it into several different buckets. And this is the way we've been thinking about it as we evaluate. So as a patient's going through their trajectory, there's some of the things that we do that are much more education focused, right? When the patients first come into our clinics, for example, everyone does some kind of welcome and orientation visit. We'll have dedicated education times around things like modality education or transplant education. So a very, very intensive education type session. And then at other times, we kind of go into surveillance or what I call autopilot mode, where we're kind of monitoring the patients and making sure everything stays stable. And this is kind of our longitudinal aspect of this. We surveil them with a few things. In nephrology, we're not a very needy specialty. There's only a few things we need. We need blood work, but we also need some clinical parameters and blood pressure. You'll see I highlight a few times in here. Never would we have thought before that it was difficult to, to even know what a patient's blood pressure is, but obviously this is a problem right now. So there's a few items that we need to be able to do that surveillance. And in that surveilling time, we'll have our clinical counters, which are both visits, our formal clinic visits, and then times that we might interact with the patient between the visits, and that's where a lot of the work actually happens. And then lastly, the last bucket of care we talk about is our navigating or transitions piece, right? As our patients go through their renal trajectories, they'll access different specialists. They might change from one treatment group to another, from kidney care to dialysis to transplant and all kinds of different pathways that patients have. And so a big part of what we do is to help them navigate and find their way through those various programs. And in addition to having these different buckets of care, the way we interact with the patients is also kind of a web or complex thing. It's not just a single encounter type. Again, thinking of the prototype of a virtual visit, it's a one-on-one patient encounter that you can do with a video. That's all well and good, but here we're talking about multiple different visit types that we have to kind of consider and integrate into our care models. So there are clinic visits, which I'm going to talk quite a bit about that, in subsequent slides, our regular clinic visit. There's the care between the visits, which is, I think, a very, very important thing to highlight that second bullet point here. And this has been very clear through the pandemic. One of the reasons that we've had to keep the lights on in our kidney clinics is that addressing issues keeps patients stable and keeps them out of the hospital. And that's a very, very important thing. And that all happens, a lot of that happens between the clinics. It's not something you're doing in the clinic visit. And then again, we have these education sessions. And then the last point that I want to put there that's come up more and more is our documentation. It's not a direct interaction with the renal patient, but we need to be able to share that information when we do interact. We need to be able to share that with each other within the renal team. We need to be able to share it with all the other providers who may interact with that patient. So that's another a key consideration as well. So this is the various ways that our teams function and interact with the patients. And the other point that I want to make before we start getting into the evaluation is we weren't looking for a big change. These are just some things to say that we've had these well-designed models of care, and we have good evidence that this improves patient outcomes, that rather than me working alone as a single provider, us working together in a team of people improves all kinds of different outcomes for our patients. I won't go over that here. It could be a whole talk in and of itself, but it just suffices to say we weren't looking for a wholesale change in the way we deliver our care. We're always refining things, but not this big bang type of change that we had. And it's important because had we wanted to do some change, we would have done it as a planned body of work with a structured evaluation to make sure we knew where we were going with it. Whereas here we were just kind of thrown into it, having come from something that was actually working very well for us. Now, so since it was working so well for us, the way that we've been thinking about this as we talk about moving into the future is that we really want to import our philosophy of care into the new environment. I don't like to call it a new virtual setting. A lot of things talk about importing our models into a virtual setting, because it's not going to be. It's going to be a hybrid setting. We're all seeing this now. It's going to be some mix of what we were doing before with some new tools that we hadn't been using. But as we go to this, this really is my mantra, and you'll see me put this on the slides over and over again, that as we provide care, we're going to have to determine what's the right visit type for the right patient at the right time. We used to always say the right care for the right patient at the right time. Now, within that, we even need to think every single time we're interacting with the patient, what's the best format to do this in? Because we do have a host of different options available to us. So along those lines, I can take you through some of the learnings, and I'll take you through what we've learned over the last year, and then now what we've been doing much more with a structured evaluation. So the first part of this is we've had, ever since right at the beginning last March, a year ago now, sobering to think that, but a year ago now, we struck up a working group within our kidney care committee to talk about virtual health. And in the first instance, it was really us just trying to figure out, what the heck do we do with this? Let's all work together and learn from each other to figure out where the heck we go. And now over the last year, that group's really evolved to a place where we kind of share what practices are happening in the different clinics, figure out what challenges people are addressing so that we can address them together, kind of share the pain approach rather than everyone being on their own. And so from that group, we've had a lot of rich feedback. And I like to be honest about it. That's why I have here that, we will talk about the good, the bad, and the ugly. And I think that's really important to talk about all those aspects when we're talking about a new format of care. The good, and I can't say this enough, over the last year, is that it's just so impressive how much we've done and how quickly everybody and thoroughly everybody adapted. Nobody ever dreamed of an environment like this before. We had no contingency plan for when we couldn't see patients, but yet we developed a new way of delivering care very quickly. Our patients were all cared for, and that is just fantastic. And I can't say enough about all the many people who have done tremendous work to make that happen. So that's obviously the biggest good that's come out of this. But I think we've also learned some things about virtual care that are good as well. The virtual care, as people know, have been floating out there for ages. The technology has been around for a long time, but this was kind of the kick in the pants we needed to actually implement it. And we've learned some of the great things about it. In some ways, it can be faster. And especially what I think we've learned in the kidney clinic context about that is sometimes all you need is just a quick check-in. We were doing this to some degree in the kidney clinics where we modify which providers saw patients when they came in. But now this is really driven home that at sometimes in a patient's trajectory, a quick call just to make sure everything's going okay is actually all they need. And in that time, this can be a very, very fast way to do it, both for the provider, but also for the patient who you didn't drag out to your clinic just to talk to them for 5 minutes and say they're doing okay. So that's definitely a good thing, and the convenience factor kind of fits into that as well. The other thing that I think we've learned, and this is really strong feedback from our working group, is that some of these virtual platforms actually are the best. They work really, really well in these in-between clinic components. So for example, we've taken tasks out of the clinic, which I'm going to show you in a few more minutes. So I'll come back to that. Things that used to be time consuming in the clinic, we can do with this support. But one of the other big strong pieces of feedback is that with visits with clinicians between clinics is working very well. Our almost uniformly dietitians are loving this, and why it's not that I'm saying there's anything specific about them that they can use the virtual tool. I think it's that they're a group that have always felt maybe a little bit limited with the time that they can spend with someone in the clinic, whereas by removing that, but still being able to easily connect with the patient, they can actually go into a lot more depth. And so the feedback's been very strong there. And then the last 2 points I want to say that have been very good is our education webinars. So we've done these type of education sessions for patients for a while now. This started with transplant, was one of the first ones that we were doing. They were predominantly an in-person thing. We did always video conference to sites, but on the distributed sites, the uptake was variable. Whereas now, since last March, these sessions are very, very well attended, to the point that we now have a monthly patient education webinar that we host, and they're highly attended. I think just because people have gotten used to going onto a Zoom and seeing a webinar. And so it's a great way to actually get some education out to a wide group of patients. And the same thing for staff. Our staff education webinars are better attended than they've ever been. And I think part of that is just now people are used to logging onto a virtual meeting and interacting that way. Now, the bad things that we've learned is that there is quite variable support for these tools across the province. And so some places are disadvantaged in that they just don't have good IT support. I don't think it's a surprise to say that, some of the shine of this has worn off and people are sick of phone calls. It's some days that a lot of clinicians will say that. You look at your list of, all these people to call, maybe you've got a couple coming in person. You're kind of looking forward to that because the rest of the day, you feel like you're playing telemarketer. And so people are a little bit done with that. The efficiency is one that we're going to be evaluating because there's convenience factors and quick things about virtual health. But if we lose all of that by playing air traffic control, as I call it, trying to figure out who's seeing the patient and making sure people can connect, we might not be coming out ahead. Forming relationships is difficult. I'm going to spend some time specifically on this. And we just know that that some people cannot interact well with this. And it's not a fault of the person. I think it's actually a very difficult thing to really fully engage when you're just talking to someone on the phone or seeing them in a visit. And we know that that's variable. And we've also, through our working groups, we've seen staff are noticing that there's kind of increasing disengagement. We've all had the experience where you call or want to have a visit with someone and you can tell they're driving in the car or at the supermarket and you're not having that same type of interaction as you were having before. And then the ugly, and I think we all know there is some ugly, and one of the biggest ones is we know this is not a replacement for in-person care in a lot of settings. Again, there are some things that lend itself well to doing this, but sometimes you just need to see a patient. And I think however we dress this up, it is not a replacement, and I think that's becoming more and more clear. And the ugly part is that sometimes you really want to see the patient, but for whatever reason, you're told that you can't, whether that's because your clinic doesn't have the capacity to have a certain number of in-person visits, or in some cases, the patients don't feel comfortable coming in. And it's not a good feeling to not be able to provide the type of care you want to provide. Some of our team members are feeling cut out. Now, I think this is hopefully improving, but some of the team members were feeling left out of this. And again, we never want to damage that integrated network that we have. We also know that some of the collaborative relationships we built on are struggling. This is not a huge secret, I think, to many of the care providers, but we've seen that our patients have quite variable access to primary care. Some of the primary care providers are making Herculean efforts to make sure that they're still seeing their patients, but patients are reporting they just cannot see their family physician. And when we're talking about sharing care with primary care providers, if one half of that balance is gone, obviously it impacts what we can do on the other end. And then the part that I think we all are worried about is we might actually be worsening the existing inequities. So people who can't access this being one, but also people who have difficulty with self-management. I bring up blood pressure, quite a few times here because we're realizing that there's a group of patients who it's not something that they're going to be able to do to monitor their own blood pressure. And that's just such a cornerstone of what we do in renal care. Whereas someone who's able to do that now all of a sudden is getting kind of better care because they can give you that information to feed into your decision making. And so we don't want to be worsening what already exists as an inequity there. So that's some of our subjective feedback that we've gathered over the last year, and it's not a surprise, and some of the people have heard that. And we've used that to inform various guidance documents that we have, and these are all available on the website. These have been up for a few months now. We've been updating them every couple of months as new things develop. And we have two documents. We have one that gives guidance for our clinics in what we call the restart phase. That was the new term, meaning when things are okay and we're kind of on a level playing field. And then we have the other that talked about the acute phase. This was important initially, but also there have been a couple of clinics that have had to go in and out of that as numbers have gotten bad in their various regions and they've been worried about losing staff. So we have the, how do you do the core task? That's the acute phase versus what do you do the rest of the time? And we have, based on the feedback from our working groups, we've talked about this, how you for example, integrate various different types, how you choose a patient for a various different type and some practical considerations. This is all based on us working together. None of us knew the right answer, but our working group, we put these documents together. So we've had these up and we've been using these for some time as guidance. But now as we move forward with this, I think we really, really need to be having more information. Our choices really need to be data driven. You know, none of us going into this knew what the right answer is. We still don't know what the right answer is. So this is going to be an iterative process to really integrate our various care models. But now as we have more and more time and this is becoming a routine part of what we do, we really need some data and some evidence to inform this moving in the future. How do we continue to refine this integration of different care models? So this is what we're doing now. And it's a great body of work that we're doing. It's not a small thing to do, and we'll talk about this in a second. And we've got a lot of people working on this. So we've got great support from the BC Renal side, as always, and we've got a collaboration going, and we've partnered with the PHSA Office of Virtual Health, who's bringing their expertise in this to the table as well. And the nice thing, the really, really nice thing is we're not starting from scratch here in terms of the way that we're going about this evaluation. It's very timely that just last year we had kind of approved this very, very thorough guide to project planning and evaluation. And this is a big evaluation project. So it's nice to have this BC Renal framework within to operate to do this. And we're using other existing tools out there. The one you'll see me highlight, for example, a couple times here is the BC Health Quality Matrix. So it's nice that we have some existing tools to lean on. And I would really suggest that to everybody as they go about any of these large body of works to go back and look at what we already have just as a starting place. So it's great that we have all of these in place. And now we've got a big body of work in front of us. So we have now developed, and we're in the middle, it'll show you we're in the middle of our second phase here, of a more systematic evaluation of virtual kidney care. I have here our big lofty project goal, which you can see I snuck my favorite words in there of the right visit type for the right patient in the right time. But really it's about, evaluating the various aspects of this care delivery and able to inform that, to inform how we move forward with this and best integrate visits for our patients. And we've broken this into several phases. The first is that we just need to know what's happening out there. So that's our kind of current state, the first component. Then our second phase is actually figuring out our patients, our care providers, and our teams. What are they experiencing and what's been the impact on them with virtual care? And then lastly, we'll look at our key metrics. And by integrating all of this, our goal is to really figure out which tools are best for which patients at which time. And that's what's going to serve us in the future. So our first component, we had this nice survey. Some of you saw that went out. I want to say, I should stop here. These are a lot of the slides that I've stolen from the OVH team. I want to give them their credit here for preparing that, which is great. But yeah, so this is our survey that we did up until the end of January, where we surveyed all of our clinics. You can say that we say 15 out of 15 responses. That sounds like a very small sample size, but the goal was actually we had one respond per clinic. So we had one operationally minded person who knew exactly what was happening in each clinic, go through a fairly detailed survey for us to just figure out what is the lay of the land. We kind of knew anecdotally, but we needed to actually put numbers to this. So the first thing to talk about is, sorry, I should pause. There's going to be a full report about this that we'll send out to everybody. Here I've just pulled out some of the highlights, but the PHSA team actually is going to prepare and will disseminate a full report on these findings. But the parts that I pulled out, so the first item was, what are people using? And this is kind of, not a surprise. There's phone is being used very, very heavily. But the nice thing to see is that when we went into this, we knew there was variability in what tools people were using because it was very health authority dependent. And the thing that makes our job maybe a little bit easier, hopefully, is that there's really only 3 things out there that are being used. It would have been a very, very scary and daunting evaluation if people were using 10 different tools. But at least when we talk about this more and more, we kind of have just a small group of tools that we need to really talk about and hone down. Not a surprise about the phone. And actually, we see this borne out. This is what I think a lot of us knew anecdotally, is that a very, very a large amount of our visits are happening by phone. So this is the clinic names are all listed here. This has been shared with everybody, so it's not a secret, and everybody has shared it. And as we go through these variability, the other point I want to make, it's not that we're saying one thing is right and one thing is wrong. This is just to describe what's happening. We know there's variability. None of us know what the right answer is. But at any rate, yeah, this is what I think most of us already knew anecdotally, is that the vast majority of what we're doing is by phone. So in some clinics, this is, this is over 3/4 of their visits. In the vast majority, it's well over half of our visits are being done purely by phone. So right now, when we're talking about virtual health, we're actually talking predominantly about phone interactions with patients. And that's an important way to frame this. Our video conferencing in most areas is a much smaller proportion of visits. So you can see that the most common thing is that this is less than 1/4 of our visits is happening by video. But there are a couple places who have very highly integrated it. So that's that variability piece, right? Where we see that, and again, we don't know where the real solution is here, but we have some who have almost completely shifted to a video visit format, and others where it really means we're seeing, we're using this very, very little or not at all for some places. One of the other items we wanted to talk about is what about the traditional telehealth setup, the facility-based, meaning, the patient and the provider both go to a specific location that has a little cart and is set up to do the conferencing. And this still has a role. A lot of places aren't using it, and actually they really never were, but still some places are using this quite highly. And it's an important thing because when people started using Zoom, they thought this was going to be extinct or obsolete, but clearly this still plays a role, and we're still providing care for a lot of patients this way. And then, of course, what about in-person visits? And almost hands down, this is making up less than 1/4 of our visits. Again, not to say what's right or wrong, but I think if this is one that if we were to hone down, and we'll try to with the evaluation, we'll probably see it increasing over time. I think people have gotten more comfortable physically seeing patients, but we still know it's a vast minority of care. Again, before, this was almost exclusively what we did. We were not looking to change, and now all of a sudden it's the vast minority of what we're doing, right? So an important thing to conceptualize. Now, I'll apologize because this slide shows a lot of words on it, but I wanted to put these all together because I think this is one of the most interesting things that we found. Now, we saw before that the vast majority of things are happening not in person, so either by video or phone. And of those, we know most of that is phone. But then we tried to break this up and say, well, depending on the task you're doing in the clinic, is that different? And so it's not a surprise that for our routine clinic visits, it kind of follows that pattern we saw earlier where it's mostly virtual. And for our assessments with one-off clinician visits, a dietitian, social worker, what have you, that's also being done pretty much virtually. That matches with what we saw earlier. But then we start to see a little bit of a shift. For down here, we have our welcome or orientation visits. So most kidney clinics will do a more thorough first visit with a patient. Or we have our educational type visits, treatment modality decisions, transplant decisions, or education, big education sessions. And we can see a shift now where there's still, of course, a lot of virtual, but we're starting to see more people doing this in person, right? So mostly in person or equal amount on both of these slides. So we're seeing a shift where now people are doing more of those types of visits in person, which we'll be drilling down with this in the next component. But to me, this is evidence of people kind of voting with their feet, so to speak, of saying those tools that we're using for most of our stuff actually isn't quite cutting it here. So we're kind of shifting and actually bringing the people in to do this. So we are seeing a difference depending on the type of task that has to happen that day. A couple of other points that are important to think about. We asked if people actually have some kind of set criteria, some algorithm or some tool that tells them who gets a virtual visit and who gets an in-person visit. And the answer there is no. A few places are using a set criteria, but that doesn't really exist to a large extent. We do have some suggestions in our best practice or guidance document we have posted, but to date, everyone's doing this basically on a case-to-case basis, just making a decision that clinic. And then this is the second most interesting thing I think from this clinic is that what we used to call one clinic visit now means all kinds of different things. So it used to be with a KCC, if you went from one KCC to a different KCC, what you were seeing for a clinic visit was more or less the same thing. People would come in, they would see a bunch of different providers on that same day, and they would go home. But now this isn't the case. So for our virtual visits, we have the most common thing is that still we'll try to replicate that model where multiple providers will see them on the same day. But then we have other things happening. We have some places where everybody actually sits in on one Zoom call together with the team, which is not really something we were doing before. And then we have yet other places where it's actually a visit is spread out over multiple days. Some providers on one day, some providers on another day. And again, this is one of these things, we don't know what the right answer is here, but it's just interesting to see that variability. And now when we're talking about a clinic visit, it actually means multiple different things. Same thing with our in-person visits. You know, this was for our virtual visits, but for our in-person visits, same thing. Even on those where it used to be when someone came into clinic, they saw everybody that day, almost hands down. That was the most common way of doing it, where now it's a very even split. So even when we're talking about an in-person visit, it's not quite the same thing that it used to be before. In a lot of cases, it means actually you're seeing some providers in person and others will connect virtually at a different time. We've brought specific tasks outside of the clinic, which I think is, this is one of these wins. And that's why I have these little boxes here. Some of these were fairly time-consuming things like medication reconciliation, for example, or ASAS or symptom assessment. And a large number of clinics now are actually doing that not in the clinic. And I think this is something we're going to keep with us because a lot of clinics have found huge efficiencies by doing this. Rather than someone going through the medications one by one while the patient's sitting there and paying for parking and waiting around and all that type of stuff, you know, that can be done prior to the visit. So a lot of people have shifted tasks to actually be outside of the clinic situation. And then the last couple of items, this is not a surprise, but just to say that different clinics have different amounts of IT support. So some are getting all their IT support from an actual health authority type person, whereas other places, basically the IT support is to ask your friend down the hall because they don't really have good access to it. And then we see the same thing when it comes to patient IT support. So people are using a host of things. There's some stuff out on the website, some health authority ones and things like that. But this last box, I should have put a red box around it, is the one that I really want to highlight, where people are our clerical staff are providing a lot of that IT support. And this is not something that they were doing before. And of course, is a time-consuming thing. So something that we'll have to think about. And finally, I think it's an important point. You know, we need to be able to communicate with our patients, and the various privacy gurus have made this easy or difficult depending on which health authority you're in. So we have some clinics that are able to email back and forth with their patients, including clinical information. Say, can you email me your blood pressure? I'll send you this. You know, and that actually is obviously very important when we're no longer able to hand things back and forth to a patient. Whereas other clinics have basically been told the only thing you're allowed to do is send appointment notices. There can be no patient level information in emails. And it's almost an even split. So an important thing to keep in mind when we're talking about communicating. So putting this all together, we have a lot of rich findings here. And you know, that was kind of the whirlwind through it. But I think that the big message is there is a lot of variability out there. It's interesting to see the way that people have shifted depending on what tasks there are. And we're going to be drilling down more on that. But I think the take home from this is that what we call a clinic visit is no longer one thing. It's many different things. In one location, it can be many different things. And across the province, it's a host of different things. And the other big point is that this is all to say we don't really know what the right answer is here. This is something we're going to have to learn together, and we still have to learn together. I'm sure what we'll end up saying there is no one right way to do this. But as we start to drill down on this, there's a whole lot of different variables we need to consider in our clinic delivery. Okay, so that was our first phase of the evaluation, just saying what is the lay of the land when we're talking about this. But now we start to get really into our phase about what's the impact on our patients and providers. And again, coming back to this philosophy of the right patient visit, or the right visit for the right patient at the right time. And I want to kind of break this down because this is going to inform this part of our evaluation that's actually currently underway. So this is wordy, and I'm not going to read everything out. I put this on mainly so that when people download these slides, they can look through it a little bit more. But I think it's good to say, what do we know and what do we not know so far? And there's obviously a lot we still have to learn. But when we're talking about finding the right visit type, video or phone or things like that, right now we have to keep in mind that actually phone is still the majority of what's happening out there, right? So when people are talking about virtual care, it's still predominantly phone. And when we're making that comparison then between an in-person visit, we're actually comparing it to a phone, which, you know, may not be the same thing whatsoever. We know from our feedback, and this is coming through loud and clear, that sometimes you just cannot replace an in-person visit, no matter what the health authority, you know, IT gurus or whatever wanted to say and talk about going to a virtual clinic. That's never going to be the case. We're always going to see people in person, and sometimes that's the only way to do things. It's also important, you know, that this traditional telehealth setting cannot be forgotten. I think where it probably plays the biggest role is places where connectivity is an issue. That's why some of these still exist in communities where this is actually the only way to get a reliable video connection is to go to a site. So we can't leave that out of this equation. And the last thing that we know, hands down from our working groups, is that it's very difficult to integrate multiple types of visits into one clinic, meaning if you're seeing some people by in person, some by phone, and some in video, actually you have a really complex clinic to just run operationally, and we need strategies to assess that. So these are some of the things that we've already learned. But some of the items that we still definitely need to figure out is this aspect of quality. And, you know, I'll come to that in a second, but basically, before we even say, are we providing good care, how do we define good virtual care? I was really hoping that at this point into this, we would have more standardized and set tools to assess this, but to date, that's not really the case. Some are just starting to come out, PHSA as one that they've just about to release, but you know, 1 year in, we don't have a standardized way of assessing what's good virtual care. And so we need to figure that out. We obviously need to figure out if there's a difference in the quality of care between these visits. And I'll take you through exactly how we're going to do that in a couple of minutes. And in addition to the quality of care, I think we also need to think about engagement. Do both our patients and providers engage in different ways? Because that's going to inform, you know, how we go about this patient selection or this visit selection. In terms of the right patient, I think there's a couple of things that to talk about. Not everybody can access virtual care. And this was the other thing I just said, was not everybody can engage in this. And those are separate items, right? Do you have a computer is different from, can you actually interact in a meaningful way? And that's a very individual thing. And what we've learned is this is not who you expect. You know, I'm kind of tired of always hearing the example that, oh, well, we have elderly patients and they can't connect. Well, you know what? We have a lot of elderly patients who can connect very well. Thank you very much. You know, I'll have a video visit in my office with, you know, an 80-year-old patient. Sometimes they have their daughter there with them or what have you, but they can interact just fine. Whereas we'll have, you know, a 45-year-old patient who can't figure out how to pull up the video link, right? So I think it's not who we expect, and we have to kind of put that away of putting people into chunks and saying these patients can't engage virtually, because it's much more nuanced than that. Blood pressure monitoring, I keep bringing up because it's just so important in what we do in the kidney clinic. And essentially we've outsourced this to our patients when we go to a full virtual model, and not everybody can do that. Right. And if it's been 2 years since you know what somebody's blood pressure is, that's a problem. And we're kind of getting to that territory. What we know also is that very few people are using kind of set criteria as in the current state to determine the right patients. And I think we want to move in that direction, hopefully. And of course, there's both challenges and benefits for integrating other people. It might be easier to integrate loved ones, but you know, it was also quite fairly easy to gather people into a clinic, or very good to gather people into a clinic and talk to them together. Translation is something we're going to bring up as well. What I think we don't know, so we know though, and those are all fairly intuitive things, but what we don't know is, are we doing a disservice to people who can't engage? And the very, very specific question that's always on my mind is, are we continually disadvantaging the same patients? Right, because you could kind of see that the type of person who has difficulty accessing virtual visit might also have difficulty engaging with the team. They may also have difficulty interacting and seeing their primary care provider. They might have difficulty monitoring or doing self-management of blood pressure and other things at home. So all of a sudden we've got the same person who keeps getting strikes against them. And is it the same patients being disadvantaged? And that's the thing I really, really worry about. So I think we need to assess that. We don't know if there's different experiences in different language groups and different cultural groups. We're using a cookie cutter model right now when we talk about video visits, but maybe that's not the right thing to do. We just don't know that. and we don't know if it's feasible to have a practical framework and a questionnaire or what have you to determine who's going to succeed in a virtual visit. We don't know that, and it's something we need to figure out. And then as far as the right time, so the right visit, the right patient, and the right time, we know that people are using different tasks for different visit type for visit tasks. So people clearly have identified that there are different times where one tool works better than one doesn't, but we still don't have a great way of assessing what's the quality of that. Do some visits lend themselves better to virtual care than others? So we need to assess that specifically. We need to learn that. What we do know is it's difficult to form relationships virtually, and especially when it comes to big decisions. And this has been documented in the literature before, and we're clearly seeing this now. That's why I have my picture of Norm here. When you have somebody who's been in your clinic for years and you have a very strong relationship with them already, you can actually just pick up the phone and check in and say, how's it going? And you can still have a very good interaction that way. But there are now some patients who we've almost never seen in person, and perhaps are getting ready for things like a transplant or dialysis. I mean, just think about that. You've maybe seen them once face to face, and now you're taking them through life-changing decisions all over the phone or on video, right? That's a very different type of relationship. And we have people who, who can interact and make a relationship that way, and others I think who can't, and we need to recognize that. And then the last point is, we have some people who have not been seen in a very long time, and we don't know if there's some frequency in which we need to be seeing them. So we better figure this out. So for all of those items that we have to learn, that's where we're in the midst of our second component of this. And so this is the component we're working on right now. It's all laid out on one slide. Putting it on one slide really undersells the amount of work that's going into this. We have quite a few people engaged, but I just want to tell people this is where what we're doing, and this is what you'll be seeing in the months to come. So as I mentioned, there is no one way to evaluate this. I was really wishing by now we would all have a standardized way, not just in renal, but everywhere, all care settings, to evaluate quality of virtual care. All the tools that you see out there so far, the majority of them so far, are really about just the tool itself. Could you connect? Could you see the provider? Could you hear? All that type of stuff. Not that that's not important, but that's not what we're getting at here. We really want to get at what is the quality of care, because that's going to inform how we choose which visit types to use in which situations. Since there is no one preset tool to evaluate this, we've kind of had to go it alone. But again, the nice thing is we're coming from a place where we have frameworks to work on. So what we have planned, and what some of you are going to be seeing and being involved in very soon, is an evaluation for both our patients and our providers to look at these various aspects. So we've mapped out based on this existing health quality matrix. And it's important because when we're talking about quality of care, we need to define what does quality mean. And this is a tool that actually does that very nicely, where we talk about different dimensions of care, different aspects of care. These are the ones that we talk about for patient. There's a couple more for providers that include efficiency and things like that. But so we have, you can see these dimensions of care, which are quite, when you look at it, it's quite intuitive. So what we've done is we've talked about what does this mean specifically in the kidney care context, in the renal care context. So we've actually broken that down. And then the way we're going to do this is we're going to have structured interviews, because some of this is only ever going to be qualitative information. And we're going to have quantitative information or structured surveys or questionnaires that we deliver to our patients and our providers to get at these. And putting those two together, we'll start to get a picture painted of what is the experience and what is the quality of the care we're delivering with different formats. And only then, I think, will we be able to make have an informed discussion about what's working well for what situations. We really need this. So this is something that you'll see coming out over the next couple of months. We were hoping to have some of this done even last year. It's for various reasons. It's a giant body of work that's taken a little longer to put together, but I'm actually glad with the way this is shaping up, that I think we'll have a very, very robust set of information here that frankly nobody else really has right now. So by putting this together, we'll really be in a good place to talk about our care delivery moving forward. And that's kind of the thought that I want to leave people with. I know right now there's light at the end of the tunnel, and we're all hoping to get out of this, and that's great. I think we all can't all wait for that. And one day we'll be able to have rounds and sit together, for example. So that's great. But I think it behooves us to now leverage what we've learned over this last year to enhance our care delivery in the future. It would be a shame if we all struggled and really struggled and went through all this pain in the last year and didn't take some good learnings on the other end of it that we can actually use to potentially forever improve what we're doing. And so that's where I think that doing this analysis and having this data to inform our care delivery is going to be very important. And so I'll kind of leave it at that. That was a whirlwind tour of all the activity that's been going on over the last year to evaluate a care delivery. And I think these are the couple points to remember. And the last thing I want to leave with is that again and again and again, there are so many people working so hard to keep our clinics running and to figure out where we're going with this. And I want to make sure I'm not under-recognizing everyone. So thanks everyone for the work with this. And with that, we'll put it to questions.
Yeah, thanks, Mike. And that was really thoughtful summary and good reflection for all of us to realize how far we've come. And there's still places to go. I mean, there was one of the questions in the Q&A, and I'll ask people to please feel free to either unmute themselves if they can, or just write in a Q&A. But one of the questions was, once everyone in the province has received their COVID vaccine, do you think the patient's preference would be in person or virtual?
Yeah, so that's not a question that I can answer with one answer. I think the answer is going to be that it's different for different people. And that's where we're really trying to get to. And I can give big examples or obvious examples. If that patient needs to come in for their education visit, I think, to learn about modality selection, for example, I think we're going to say, you know what, this is not something we want to do over the phone. And we're probably going to have data to prove that that's not a great way to deliver it. But if that patient lives 2 hours out of town and has been stable and you're just doing a quick check-in, well, probably they're not going to want to come in, and probably, reflecting, it was maybe silly of us to bring people in for a 2-minute check their blood pressure, say thumbs up, go back home. So I think the goal with this is not to say that there's going to be one way of doing care. It's going to be for us to have a data-informed way to select the right one at the right time.
Yeah, and I think, just to highlight one of the things that you brought up is that those visits, there's a lot of data on adult education and socialization of a chronic disease, and not to underestimate the fact that one sits in a waiting room with people like self and say, oh, I'm not alone. And then you meet people, and yes, your visit takes more than 10 minutes, but that's important for us to actually understand, right? And then be able to, how do you reproduce it virtually or not? Because that's the whole thing about chronic disease management. It's not a one-off, and it is the repeated visits that I think are really important, and how one spaces those in a balanced way is something that we'll have to figure out for sure.
Yeah, absolutely.
There is another question. So Helen, thanks for the presentation. For evaluation, have the dimension components been validated by patients and the frontline clinicians? How do you know if those components are the ones that matter most? I think that was that quality matrix.
Yeah. So yeah, exactly. So that's a very that we're drawing from. That's a very well validated tool. And then we're in the middle of our development right now, but we do have our patient partners who will be vetting all of this. We're still constructing our tools a little bit still, so they haven't given all their feedback yet. But yeah, we have an excellent group of patient partners that we'll be vetting this with before we go out further with it. As far as the providers go, well, that's that working group we've had for the last year who's been informing this, so that we have, I didn't go into all the details, but we have membership from every clinic across the province. Now, not everyone can make it every time, but we vetted this with everybody across the province. So yeah, that's exactly our goal, is to make sure we've got the right aspects, especially since we're essentially making it up as we go, right?
And remember that in a moment of panic, both patients and providers opted for not seeing each other. And then after a while, as you said, one might get tired and say, actually, there's something nice about those visits. So what works for this year may not work for next year. So I think that's another important thing. I think, Shauna, you have a question that you wanted to ask, and Brenda can unmute you. Well, now here you go.
Yeah, thanks, Mike, for the presentation. And actually, it's just kind of along the lines of what you were just chatting about. Is we did in the post-transplant clinics, we did a survey on patient satisfaction with our virtual clinic between March and June, and the satisfaction, our response rate was great, and the patient satisfaction was exceedingly high. I suspect that a lot of this was due to feelings of safety during the pandemic, and so I think it would be important in the survey that you're putting out to make it iterative, because I think it, you know, as safety improves, or as we hope it improves during this pandemic, I think that people's feelings will change about what kind of care they want.
I think you're exactly right. And so there's 2 points there. One is that's fantastic. You did that work, and I'll definitely want to see that. I haven't seen that yet. But one of the things that we want to make sure we're not conflating is what's the convenience, or the feeling of safety of not having to come into the clinic versus the quality of care we've delivered. And to me, those are actually two different things. And that's what we're seeing with a lot of our feedback too, from the preliminary stuff we have from health authorities, is people love it. They love not wanting to come into the clinic. That's great. And that's an important thing. But when it comes to some of these very detailed tasks, maybe that's not the best way to be doing it. And those are slightly two different questions. I agree with you about it being, iterative. It's a shame we hadn't done some of this before, but now once we do have this set, it'll be one of these interesting things to be checking in periodically, because then we'll have that baseline and that comparison. And I agree 100% with you that is going to change as time goes on.
There's very little time left, but there are two. One is from Carolyn Stigant, that the pandemic opportunity of virtual care fits into the emerging model of planetary health provision. And this is certainly important for sustainable and green nephrology. Yeah. And that the appropriate hybrid, I think we'd all agree. And to Shauna's point, it's about what's right in the moment, and how do you get people to feel safe and supported. And the related question, which I think addresses some of what you were just saying, is, maybe one of the things we can do is, when patients' families need to be also involved, and maybe virtual health with whiteboards and polls and various other things that really do allow a family who can't necessarily come during working hours to an orientation, et cetera. There are some interesting opportunities to think about. Yeah, exactly. I agree. And it's not just as straightforward as inviting them to a Zoom. That's what we've learned. Right. There's opportunities to involve them, but I think that's a great comment, Ben, is that there's a difference between someone signing on to a video and someone actually engaging in this, and those are two different things. I totally agree with that. Yeah, no, it's a strange new world, which will continue to evolve. There aren't any more questions. I want to thank you and the team, and you've been very good about acknowledging the fact that this is certainly a team effort, both in the launching of virtual health around the province in whatever form it took, and supporting the patients, which is always an amazing thing. Morag raised a hand. Okay, one more. There you go.
Hi, can you hear me?
Yes.
Oh, hi. So this is Morag McGregor. I'm with Island Health, and I just wanted to touch on what the previous speaker had mentioned about the survey that they've done. And I just wanted to highlight that Island Health have also developed a survey within renal services, specifically about the experience of the virtual visit. It took a bit of a while for us to get our workflow in place to get these surveys out to patients after all of the virtual visits, but that's really sort of picked up since the beginning of the year. And again, we've included some qualitative information around that as well, around how patients want would like their visits to be scheduled on the go forward, and if there's any way that we can share kind of our experience or process, we'd be happy to do that.
I was going to just say yes. I think Mike will be in touch with you. Yes, that would be great.
Yeah, would love to hear that. So please do connect with me. Or
that would be fantastic.
For sure.
Yeah. Anyway, Mike and all of you, thank you for all that you've done to support everybody through this rather amazing year. And it was just perfect timing for us to reflect on where we've come. So thank you. And yeah, it was a fantastic show of people on a Friday morning at the sort of beginning of spring, up to 70 people. And your thoughtful reflections, Mike, are always welcome. And all of you working together to actually keep our patients safe and educated. And yes, there's been some hiccups, but I think we've ultimately done a great job. So thank you all. And thanks for preparing it, Mike.
Oh, absolutely. And yes, thanks everyone. If I've forgotten anyone on the screen, thank you to you too. Everyone's done a tremendous amount of work.
Yeah, great. Take care.
Take care.
Bye-bye.